All right, ladies, we are live for our broadcast for our discussion question, and I am starting off with discussing the new Pap smear screening guidelines. Some of the things that it points out are that they're changing the intervals that they're suggesting for screenings. They're actually suggesting that screenings be for ages 21 to 65 and to end the screenings at age 65. One of the big focuses with the Pap smear screening is going to be looking for HPV. And as it goes through the cancer screening guidelines that are based off of ACOG, that is really going to be one of the differentiating factors that they look at. One of the suggestions that they give is it used to be thought, I know that once you're sexually active that you should get a Pap smear. And unfortunately, we know that people are sexually active younger than 21. But they actually said that the first screen shouldn't be until you're 21, and that actually ties into HPV and the fact that they're actually aware that HPV is so prevalent amongst the young. But the fact that they typically clear it with a healthy immune system, what they're saying is that there's a high rate of clearance, and what they feel like they're doing is too much testing, and they end up doing unnecessary colposcopies. They may end up with a leak procedure that will then cause them to have their cervix compromised at such an early age for something that their system was going to clear anyway. So that was one of the suggestions, to wait until a person's 21, although they may have been sexually active prior to that. And then for the age group of 21 to 29, instead of getting a Pap smear every year, this suggestion is a screen every 3 years with cytology, either liquid-based or conventional cytology. And with that, a lot of times they will reflex and look for HPV. That's not what's in the book. It's just true. And then the bigger change is for women ages 30 to 65. For ages 30 to 65, they are going to automatically test you for HPV. So what the new recommendation would be is a screening with cytology with a Pap smear every 3 years, but only if you have had 3 consecutive negative screening tests, no history of CIN2 or CIN3, and then no risk factors such as HIV, immunocompromised, or exposure to DES, or with a cytology and HPV testing then every 5 years, which I know is something for women to get used to because women are used to going every year. And then they do give the rationale, which is, again, if you've had these negative tests, the low risk of cervical cancer, if 3 prior screening tests documented as negative, especially if co-testing with both cytology and high-risk HPV DNA is negative. Then moving past age 65, because if you haven't had any screenings, they actually jump to women who have had a hysterectomy, and they give them special guidelines as well, that they can actually discontinue screening if their hysterectomy was for a benign indication, had no prior history of high-grade CIN, and their rationale is because they have a very low risk of vaginal cancer. And then if your history for a hysterectomy is because of CIN2 or 3 or cancer and cervix is removed, continue to have annual screenings then for 20 years after the post-surveillance period. And then their rationale for them to keep getting them for 20 years is because they're still at risk because they did have a cervical cancer risk as the reason for their hysterectomy. And then moving on to the women who are 65 or older, they are able to discontinue their screenings if there are more, if there are 3 or more negative cytology tests in a row and no abnormal tests for the past 20 years. And their rationale is a low risk of cervical cancer because cervical cancer develops slowly and risk factors actually decrease with age. With these, for if I agree, I actually do agree with the testing. I've worked in OBGYN offices when some of these changes actually started coming through. So some of the things that we learned, especially with the HPV testing, is previously when women would get a Pap smear every year, we did not automatically check for HPV. We only look for the cervical changes that it actually starts to describe in the classifications. So if a woman had a normal Pap smear and she had been exposed to HPV, but was not experiencing cervical changes. A woman could have had a history of negative pap smears and never realized that she had been exposed to HPV. And sometimes, as women, life happens, and women will then stop going to the doctor because, hey, I've had 5 years, 10 years of negative pap smears, and so I have no risk, not realizing that they have been exposed to HPV. And then they go for another 10 to 20 years and then don't start back coming into the doctor until essentially they already have cancer, and it's because they have unexplained bleeding. So with this recommendation, they now specifically look every single time whether or not your pap smear is normal or abnormal. If your pap smear is normal, they're still going to reflex and look for HPV, and specifically the high-grade HPV 16 and 18, which are known to cause most of the cervical cancers. So I definitely agree with that because I understand knowing your HPV status is just as important as knowing whether or not your pap smear was normal or abnormal. When it was abnormal, everyone knew to come back and check. When it was normal, people would kind of let it fall off their radar because they thought they didn't have a reason. Now at least women know, hey, my pap smear is normal, but maybe I've been exposed to HPV 16 and 18. And so at least from my knowledge, then I'm a person who needs to make sure that I don't go 5 years without getting a pap smear, because I've been exposed to a virus that, of course, can lay dormant and you have no repercussions, or it is one that could later in life cause you issues. So at least now women do know their status, as opposed to previously not being able to test for it. And a lot of that has been technology as well. At first it was that they could test for HPV, but they couldn't tell you whether it was 16 or 18. Then with technological advances, they can test now specifically for 16 and 18. And not just say, hey, you have a high-risk HPV, but it's the one that causes warts, where you would know if you were going to get genital warts, you would have got it by now. With HPV developing in a cervical cancer, that's a different story. And now today, they can test specifically for 16 and 18. So with it being more specific testing, I agree with the guidelines. Current evidence that it is current evidence-based practice. A lot of the guidelines are ACOG guidelines, and with ACOG and the testing that they do, they actually look at studies. They look at the evidence to support and come up with the percentages to say these are the trends that we're seeing. So a lot of times ACOG will drive the guidelines for things like gynecological testing. How I use this info for nursing education, I think it's important for us to understand, because I know even for me it's very tricky to explain to a person who's been married for 30 years why they technically have what's considered a sexually transmitted disease. And nobody's accusing their husband of cheating on them because, of course, men don't have a cervix, so how would he know he has HPV? It's just one of those things. So with us having a better understanding of what's going on, and then also that, as we know as nurses, practices change based on evidence. So we sometimes find out that we've been doing things unnecessarily, and with doing research we find out that maybe we don't have to do it as frequently, such as doing all of these colposcopies on young women and possibly LEEP procedures where we actually remove part of their cervix and then they end up possibly having an incontinent cervix when they get pregnant, if their body was going to clear this virus anyway. Also, simple things like, just like we know we still call it a hep lock, and we know we don't heparinize them anymore, and with evidence-based practice we find out we can just put saline through it and it'll still stay patent. So I think understanding the need that the only thing constant is change, that with evidence we only do what we need to do to have the best effect, and then again, why it's important to teach evidence-based to nurses is just so that we are doing what's in the best interest of our patient. And I think that was my spiel. The next part of this for my section actually just goes into the cytology testing and the results of what the pap smear would be, such as negative, or they actually talk about atypical cells, or ASCUS, atypical cells of undetermined significance. And it's just the scoring, it's not so much the recommendation. So I think that was my spiel.
All right. So I guess I'm next. um, I don't have. Well, hey, my name is Ebony. Nursing student or MSN student. I don't have a significant background dealing with women, nothing. Peds, women's health, anything. So everything I know about women's health came from the nursing book, so on and so forth. So with the HPV vaccination, it says, do you agree with the recommendations, which is, giving the vaccine to the young girls starting at age 9, and then on to 12, because of statistics saying that girls they're starting having sex at an early age before the ninth grade, 13%, and by 66% by the end of high school. But do I agree with the recommendation to start, giving these ladies a vaccination for the HPV? Me personally, no. I don't agree with the recommendation because I just feel like, although the statistics say, little, I call them the girls, females start having sex early, but some wait for a long time. So I don't think giving them the vaccination will, I don't think giving the vaccination early before they have sex is a good idea. Maybe once it's confirmed, then okay, if they want it. But me personally, I don't agree with the recommendations, and I have some stuff wrote here. I just think that based on their sexual activity, I just don't agree with it. Medicine, the more medicine a person get, it'll cause more problems to me. And just I think also it's giving a little girl, a 9-year-old, an okay, that hold on for a 9-year-old okay to start having sex, and mainly unprotected sex. How could you break down to a 9-year-old or even a 12-year-old? We're giving you a shot to help you prevent an STD. I mean, of course, some of the strains are not sexually, related, but still, in the mind of this society, they will automatically think it's a sexual thing. So I just don't agree with the recommendations. Maybe when they start having sex, then yeah, because it can go up to the age of 26. The vaccination, you give it in 3 series over the course of 6 months. So I just don't agree with that recommendation. Next question: are the recommendations current, evidence-based practice? How do I know? Well, I look at the CDC website .gov, and that's a credible source. So according to the CDC in July 2015, it's the same recommendation to give the HPV vaccination to a 9-year-old on up to a 12-year-old, and not past the age 26. So given the 3 doses of the IM injection over the course of 6 months, it's still recommended through the CDC, and it being a credible source. So I just think that's why it's a current evidence-based practice. Let's see. And like I said, in the next question it says, how will you use this information in your nursing practice and your future practice as a nurse educator? Like I said earlier, since my nursing practice does not include anything female-ish, pediatrics, adolescent, I will use this information in an appropriate setting with the age group of 18 to 26, if needed. So if I had a young lady in my presence and I'm her nurse, and the issue came up of a sexual transmitted disease, I would let her know, the vaccination is out there and what is it used for and how it's done. I also would give the available resources that I have to her, for additional information. And that's my thing on that. The last question, oh, sorry, let me go back. Nurse educator, how would I use the information as a nurse educator Same deal. If I were in a clinical setting, be in a clinic or a hospital, I would still educate that young lady on the vaccination. Let her know why it's used, how it's given, what diseases it attacks or antagonize, and I go from there. Um, as a nurse educator in a educational setting, as far as like a instructor to student setting, I would just basically do a handout on it and do a brief study on it, or maybe do a case study with my students on the actual HPV virus, a couple of the actual numbers that they have, the 16, 18, 11, all of those assigned numbers to the actual disease, and we'll go over the vaccination, because too, they got some for boys too. So we'll just distinguish between the two, which ones are for who and why. Some are given to the girls and some not to the boys. So that's how I would do the HPV vaccination as a nurse educator with my students. Another one, the last question is, why is it important that we teach our nursing students current evidence-based practice? To me, it's important because teaching them evidence-based practice from the get-go will have them ready and competent when they hit the floor, nursing floor, whatever they explore in a nursing aspect, because evidence-based practice is in all of nursing, whether it's you going through supervisor or floor nurse or however, whatever kind of nurse you want to go through. Evidence-based practice is there. It's important that the students know that we have to use it. It's current. So, yeah, that's basically it for me. I have a whole lot written down, but I don't want to take up too much time. So I will just use it, let them know it's important to stay competent, stay current, and that's it.
Good job.
Thank you.
Okay, who's next on the ovarian cancer? Christy?
That's me. Can everyone hear me?
Mm-hmm. Yeah.
Okay. So I had the ovarian cancer. I didn't see the questions until later on, but just an overview. It doesn't typically occurs over age 55. The only thing to test for it is that CA-125 test, which I read is not very sensitive and it's nonspecific. It gives false positives for so many things like benign cysts, fibroid, endometriosis, pregnancy, and one of the main things is that they don't even find it until it's already metastasized. Most of the time, two-thirds that are diagnosed, it's already metastasized, and there's about a 25% 5-year survival rate for those patients. Very vague symptoms, really: abdominal distension, bloating, urinary frequency. Someone who's over age 55, a lot of that happens anyway. They did say that the BRCA1 and 2 gene mutation is usually present, but that's a very expensive test. Unless you have a family member with breast cancer, you're probably not going to know the results of that. And that's another risk factor, is family history. If I personally had a family member that had ovarian cancer, I would go with some of the evidence-based would be prophylactic oophorectomy, just to avoid that altogether. Just like someone with breast cancer, a lot of them get the mastectomies when their sister or mother has it. How would I use it in my nursing practice? Really, like I said, the vague symptoms. So you really want to have a lot of trust with your patients. You want to be able for them to discuss things that they're really not sure are symptoms at all. As far as evidence-based practice, the CA-125, like I said, it can be an indicator, but I don't think it's specific enough. If they already suspect it, I would agree with having the test done, but they need more information after that. Why would we teach new nurses about it? Because it is the vague symptoms. You want something you want to look for. You know, if someone comes in, they've got abdominal distension, bloating, you know, all those symptoms. It could be so many things. But you want to make sure that that's something else they're looking for is the ovarian cancer. There's really no other screening test other than the CA-125, and like I said, there's not a whole lot of evidence with that. And honestly, that's what I had.
Good, good, good.
Donata, you're muted.
Oh.
Yes.
Oh, I said it's really something how. Can you guys hear me now?
Mm-hmm.
Yeah, you could be so far advanced in it before they even find it. You know, that's really scary.
And most are. Most are. I mean, 25% 5-year survival rate.
Oh. Well, that's a good job. I'm enjoying myself. Are you guys enjoying yourselves?
Yep.
Yes.
All right. STIs and HIV.
Okay. That was me, cohort here with my colleagues, and we're discussing our questions for the discussion board. Mine was STIs, HIV, sexually transmitted infections, and it was talking about chlamydia trachomatis. Did I say it right? Is the most commonly known STI in the United States, and most women are asymptomatic, and this infection usually remains undiagnosed, and if it's untreated, 40% of the women will develop pelvic inflammatory disease, and they can become infertile. And the prevalence is high in women ages 15 to 19, closely followed by those 20 to 24 years old. And African American women and American Indian / Alaskan natives are the highest risk for the infection. And it says with this infection, it's usually risk factors are less for people 24 years old if they're sexually aged less than 24 and sexually active are the risk factors. Prior infection of the chlamydia or other STIs, if you got new or multiple partners, inconsistent condom use, occupational sex work, so we know what kind of people they are. I've never seen it termed that way. And it was talking about gonorrhea also is underdiagnosed, and the treatments for that are similar. And the infection of syphilis is less common, but it's also increasing. And to improve detection, the CDC was saying that they needed to, these are the CDC and the U.S. Preventive Services Task Force recommend annual screening for cervical chlamydia in sexually active and pregnant women aged 26 and older. And in older women have an increased risk. And the screening groups for the chlamydia, whenever a pap smear is done, and they're using the nucleic acid amplification urine test for chlamydia and gonorrhea, which are equally sensitive and less invasive, and also routine screening for syphilis of all sexually active women at an increased risk, and of all pregnant women. And then they're saying routine screening for gonorrhea of sexually active women and pregnant women who are at increased risk. I agree with this because I think I have some GYN, and some of these screenings had just come about, especially the urine one. And I think it's something that should be done, and I have to agree that the CDC is a credible source, and the U.S. Preventive Services Task Force is a reliable source as well. And I would see this as evidence that these screening tests need to be done as as a preventative measure to also help people know. And I think they should be done along with the pap test whenever they come in for the pap test with annual screening. And it also talked about HIV and AIDS infections, and saying that it's growing, and it had the populations that were affected. It's account for 25% of the infections in women, fastest growing infections in women, and transmission is primarily heterosexual, and 60% are African American, 20% Latino, 17% Caucasian, and it's saying the heterosexual transmission is more likely in the following settings: infected partner with a high viral load of the HIV-1, cervical ectomy, people having sex during menstruation, and male partners who are not circumcised. I think this should be a screening as well. You know, people usually look at it, and a lot of people don't know their HIV status, but I think it should be something that's offered along with the annual screenings. Whenever people go in to have the pap smear and the yearly test, I think they should offer the HIV testing as well. And the question, I answered the evidence-based. How would I use this information as a nursing educator? I think I would make sure that I educated people to, and we all know abstinence is the best thing for anything going nowadays to ensure that you don't have anything. But I would recommend the testing. If they're going to be sexually active, I think annually, or if they feel like they're going to change sexual partners, they should go to the doctor to make sure that they are free of anything, you know, in starting a new relationship. I think that's something that should be done, and that's how I would use it in my educating when I would teach nursing students. I would teach them the importance, because with everything, education is king. If we educate and we let people know how they should handle things, I think we could prevent a lot more of the sexually transmitted infections and diseases if we would address it. And did I answer them all? Oh, why is it important to teach students about evidence-based practice? Usually people would rather know that something has it's been proven, and tests have been done, because they want to know, why should I do this? And if we've got some statistics behind it to show that there is evidence that if we would use screenings and do these type of tests, that we could just about eradicate the transmission of the infections and the diseases. And that's all I've got so far.
Yeah, it's really scary out there that it's just, you know, HIV, but people don't think about gonorrhea and syphilis like they used to a long time ago.
And it's just it's really prevalent out there. I lost my husband back in 2010, and I tell you, after being with someone for so long, and then you're having to get back on the dating scene, it's really scary. And I'm one of those people that I'll go to the doctor and make sure that I can present and say, hey, it's this way. But people look at you funny when you mention that. And I'm like, in this day and age, with HIV and all the things that happen, I've lost two really, really close friends to HIV. And in my generation, I'm a little older, trusting was the thing. But nowadays, people, you know, it's not like that. People can look at you and tell you one thing, and then something can be totally different. But I would appreciate someone that would have annual testing, you know, or when they change partners, they would be tested to, you know, be able to inform you that, hey, I'm, you know, HIV free, or I don't have any sexually transmitted diseases, and I would like to be in a monogamous relationship. But you don't see that much either.
Sorry to hear about you losing your husband. I've been divorced since 2007. And I was married for 25 years, and getting back into the dating scene was very scary. So yes, if they're not willing to get tested, they're not worth it.
Exactly. Because I say I don't want anybody paying Roman Russian roulette with my life and roaming around from person to person. It's just not safe out there.
Yep. So
I'm sorry.
Go ahead.
I like to comment on what Miss Beverly was saying about first Miss Donata was saying about how people just not really caring about the gonorrhea and the chlamydia or the syphilis, and I think it's because of the lack of education. When one would go to the doctor, they know they can just be cured of a few doses of antibiotics. They're done, and I think the healthcare provider or or whoever is educating that person to let them know, like, look, you know, this is very serious. Even though you can easily be cured of it, if it's a continual thing, you can be really, really sick. So that education part should be more in depth when it comes to those, what they used to call it back in the day, venereal diseases, like the really ones you can get rid of real quick. And I think nowadays with the HIV and AIDS, you know, back then they used to say, well, you know, you can die and all that good stuff, which you can, but now they're saying it's not the death sentence what it used to be because of the heart medications and all of the medications you could take to live a longer life. And I think that's basically making people lazy about the whole situation. Okay, if I take these medications, I'll be okay. So they kind of lax on protecting themselves or just being monogamous or what have you, even just getting tested, they're being lax on the situation because they feel like it's not the death sentence that it used to be back in the day, which the virus itself haven't changed. It's just the medication. But if you can't afford it, then you're stuck. So I think like you said, the education need to be more in depth when it comes to the diseases that's out there.
I have to agree with you on that.
Yep.
Okay, so I'm going to do the rest of this. I have options for family planning, and it talks about how the unplanned pregnancies are going up and up, you know, all the time in the United States, and that most of them, up to 65%, are teenagers 18 and under. In this family planning, it says that we need to teach our young girls and women about the timing of ovulation and their menstrual cycle and how to plan to prevent pregnancy. I agree with that, but I think the ovulation is something that you need, I think is more important if you're trying to get pregnant. But if you're trying to prevent pregnancy, there's a lot of more options out there. And because there's so many options to use to prevent pregnancy, the book says that it's more important to find the one that the couple feels comfortable with because they're more likely to use it, or to find out who what the patient is comfortable with using. Because if they're not comfortable with using it, then they're not going to use it, and then they're going to have unwanted pregnancies. And then they talked about menopause and hormone replacement, and they talked about you know, of course, with menopause, we have the mood swings, the hot flashes. It's important to help women who are going through menopause to understand the symptoms they have, what they can do to relieve it, you know, the vaginal dryness and stuff like that. But also then there's hormone replacement therapy, and there's been three studies done, and two of them talk a lot about women who use the estrogen and progesterone together have a high risk of stroke, pulmonary embolisms, and cardiac disease. And I do see, even just with birth control, I see a lot of pulmonary embolisms from birth control use in the younger girls. But I know that there's been a lot of studies through the years in regards to hormone replacement therapy, in regards to you know, breast cancer, stuff like that. So I think it's really important that if you need to use any of these hormone replacement therapies, that you really discuss this with your physician and find out everything you can about it. And only use it for a short period of time. You know, it's not something that you really need to be on for a lifetime, hopefully. So, do I agree with the recommendations? The recommendations are that, you know, we talk to our clients, our patients about the birth control method that they would like to use, find out which ones they want to use, would feel more comfortable about using. Yes, I feel that that is a good recommendation because they will continue using it. And the recommendations about the hormone replacement therapy, to use it for, you know, as little period of time as possible, and to be aware of the possible side effects and disease processes that can happen. Yes, I do agree with that. Are the recommendations current evidence-based practice? These 3 studies, it says they were from 1998, but I believe that, even though they're 15 years old, I do believe that, even today, if there was, if I had time to look at the evidence-based studies now, they would probably all say the same thing. How would I use the information in my nursing practice as a nurse educator? I would try and help, women, especially my age, I'm 53, those that are going through menopause or early menopause because of, hysterectomies and that there is help out there if you have a lot of symptoms with menopause, but to use it cautiously. Then, of course, with the clients, I would try and, talk to the teenagers if they're sexually active, to talk to them about, family planning and prevention with the type of birth control that they would want to use. And why is this important that we teach our nursing students current evidence-based practice? So that they're ready to go in and if they're approached by one of their patients, let them know what they need to say, what they need to teach them, and to be up to date on the different, birth control methods that there are out there and why it is so important. And of course, let the women that are going through menopause, be up to date on what is available and the side effects that can happen. So I was quick.
That was good. That was good.
Any questions? Any comments?
No.
I was just going to mention, when I did my BSN program through ECPI, I spent 2 weeks at Hampton Health Department. We talk about educating, and I watched them educate patients, but in my 2 weeks there, I saw one girl twice come in to be tested for STDs. And I know, every time they come in, the girl there gives them a handful of condoms and a whole bunch of information. And sometimes it just doesn't sink in. And it's really sad, but
I will say the good part about that is at least she's going to get help, and she's getting treatment possibly. Sounds like she is using the health department for her treatment instead of making better decisions. But at least she's one of the few that goes in. At least she's aware of the need to get checked. And I think for the health department, because it doesn't cost anything, what's the big deal is sometimes what we see. But sometimes half of the battle is just getting them to understand the need to come in. Just like we said with chlamydia, a lot of times there aren't any symptoms. I know for women when they come in for their new OB, I know for the state of North Carolina at least, things like the testing for chlamydia is mandatory, syphilis is always mandatory, gonorrhea, HIV, it's mandatory. And a lot of times when women come in for their new OB, they don't expect to get screened for STDs because they're married and they're in a monogamous relationship. And unfortunately, there is sometimes always that surprise that you were in a monogamous relationship, but he was not.
Mm-hmm.
So, of course, we have to do what's in the best interest of mom and the baby, even though daddy may have been cheating. Or maybe mom was cheating, and it's just a news flash to her. So I won't just blame daddy, because sometimes it is mama who has been places she shouldn't have been.
Daddy's baby.
But yeah, mama's baby, daddy's maybe.
Daddy's baby.
So a lot of the testing is mandatory that we do see. A lot of it is age, like Ms. Beverly went over. A lot of it is age. The younger you are, the more STDs you're going to be screened for. But a lot of that is probably the decision making at that age. Maybe a little older, a little wiser, a little bit more selective of how they are with their body. I think sometimes with youth, afraid to say no, afraid to say put the condom on, and then I think as people become older, they're a little bit more assertive, or are more, they're just in more control with their health. They get tested more. They understand the importance of knowing their status more. So that I think if you have a young person and they're in the office, Test them while you have them. Seems to be the guideline.
Yeah.
Yeah.
I think the teenagers don't believe that that's going to happen to them.
Oh, never.
And, you know, I used to tell my kids, it's not getting pregnant part you have to worry about nowadays. It's all the disease processes that are out there.
Or I would tell the teenagers, whenever they think you're pregnant or they think they're pregnant, I would tell them, okay, if you're not pregnant, you need to go get screened for STDs. If you thought you could get pregnant, then you could have got an STD. And that seems to be like yeah, same way.
I think a lot of it too, especially with teenagers. Can y'all hear me? Because I think I had it muted.
Yeah.
With teenagers too, a lot of stuff is on, you know, the media, social media, and TV, like the Teen Mom thing show. You know, I don't know if they still air it because I don't watch TV that much. But in the U.S., when you said, Miss Donata, that pregnancy rates in the teens are going up and up, I think it's because of what we show our kids on TV. And, you know, they don't think, oh, well, you know, once I make this decision, it's going to affect me for the rest of my life. They might think, okay, I can get pregnant and maybe get on Teen Mom, there's my fame, or however the case may be. That's an easy way to being famous, but really is not. So, but, you know, just that one show, that kind of show can distort the mind of a teenage girl, and they probably don't have a whole bunch of education from the begin with about pregnancy, or maybe not a role model in that sense. So, you know, them being educated in that way may have them think that, you know, pregnancy is the way to go, or having a baby is fun and cute, and it's really not. So that's the reason why I think that, you know, pregnancy in the U.S. alone is going up, because, you know, I don't really think they're showing that kind of stuff in other countries. You know, being pregnant is cool.
Right.
So that's my little thing on that Teen Mom thing, you know.
Well, I'll say this, and it's definitely not universal, but there has been an increase and a push for parents, especially mothers actually, for their teenage daughters, whether the child says she's sexually active or not. I've seen where moms definitely want to put their children on birth control just to get them at least through high school. So maybe can't get you through college, but we're going to get you through high school without getting pregnant. So things like the Nexplanon, where they can get it implanted, and mom doesn't have to worry about, did she take that pill every day, has been a big push, especially if a child does come and is sexually active and has an STD. Mom knows you got an STD this time, but you could have got a baby, so we are going to get treatment for the STD, but we are not bringing a baby home. So a lot of pushes come from parents, and not with birth control pills, where you're relying on a teenager to take a pill every day. They are moving for things like the Nexplanon, where I can buy you about 3 years of time and know you're not going to get pregnant. Of course, with everything else that we discussed, that doesn't prevent HPV, that doesn't prevent gonorrhea, chlamydia, syphilis, that they're still going to have to use a condom. So there are definitely some give and some take with that.
Or not do it at all, but, you know, in this society, how do you promote it? It's all over TV, the shows that you see, it's everywhere.
Ladies, do we have anything else?
I think it's all. I didn't introduce myself. I did it earlier. I'm Kendra.
Thank you for taking this over, too. I appreciate it.
Oh, not a problem. Thank you, Donata, for setting everything up.
Yes, that. You know what? I wish I had a badge or something to give you for that. Because that was nice. That email, I was like, okay, I got HPV. So that's the thing. That was really nice, and you stepped up to the plate with that one. I liked it a lot.
Well, thank you. I was getting a little nervous about it. Not, you know, it was coming up, and we were running out of time. So she has extended till tomorrow night at 11:59 to get the paper in. So we don't have to rush to do that tonight, but just to let you guys know, you know, we do have until tomorrow to get that done.
Thanks for including me, even though I work nights.
Oh, thank you. I'm glad you're... I felt
Each
bad
one
about
has
last
to do-
night.
Well, all right, ladies, I'm going to stop the broadcast, and I'm going to get Donata to help me once we sign off on getting this uploaded to YouTube. And I will do my best to get this posted into the discussion question tonight. And I think all we have to do is write our own little summary of how tonight's discussion went.
Okay.
Okay,
All right.
sounds good. Thank you.
All right.
Thank you.
Y'all
Nice
have
seeing
fun.
everybody.